Good morning, everybody. Welcome to Pediatric Grand Rounds. Just a few, the usual stuff from me before we get started. Please make sure that you are on mute if you want to be. If you have questions and comments for our speakers, please add them into the chat with everyone box at any time, and we will share your questions and comments with the speakers during the Q&A at the end of the presentation. You'll be getting an evaluation by email either today or tomorrow from our team. Please make sure to fill that out for us. It helps our speakers and it helps us with planning. And finally, just a disclosure statement from the Grand Rounds Planning Committee. We have no relevant financial relationships to disclose. And with all of that, we'll turn things over to Dr. Donna Deno and Dr. Grace John Stewart from the Department of Global Health at University of Washington to introduce this lecture and the rest of our speakers. Thanks so much, everybody, for being here.
Thanks, Suzanne. I'm Grace John Stewart, and I'm really happy to be here. And I just have one slide just to introduce people to WACh, the center that we're presenting this presentation from. We're going to talk about innovative mHealth approaches, and Dr. Deno will talk a little bit more about what that is and who's speaking. But by way of introduction, the Global Center for Integrated Health of Women, Adolescents, and Children was birthed from 3 departments, including the Department of Pediatrics, the Department of Obstetrics, Gynecology, and the Department of Global Health. And what we try to do is really think holistically through the life cycle, over the pregnancy, postpartum, first 1,000 days through adolescence and transition to adulthood, and use that life cycle perspective in thinking of the health of women, adolescents, and children. And you'll see some of these themes woven through our talks today. And I just encourage any of you who are interested in linking with us to check us out on our website, and feel free to reach out to any of the people on this call for further linkages to the Department of Global Health. With that, I'm going to pass on to Dr. Deno.
Hi, I'm Donna Deno, and I'm actually in the Department of Pediatrics in the Division of General Peds, as well as in the Department of Global Health. And I'm just really pleased to introduce this panel of speakers from WACh. I'll introduce each of the speakers. Dr. Keshut Ronan earned her MPH in epidemiology from the UW and PhD in cell and molecular biology from the University of Pennsylvania. Dr. Ronan is an acting assistant professor in the Department of Global Health at UW. Her research focuses on use of mobile communication technology, such as text messaging and social media, to support the health of populations that have been underserved and marginalized in Kenya and in the United States. Dr. Allison Drake earned her MPH in epidemiology from the University of Michigan and her PhD in epidemiology from the UW. She is an assistant professor in the Department of Global Health at UW. Her research interests include HIV prevention during and after pregnancy, acute infections during pregnancy, family planning, and mHealth. Dr. Kirk Tickell completed medical training at Imperial College London and practiced medicine in the UK, Tanzania, and South Africa before moving to UW to complete his MPH and PhD in epidemiology. Dr. Tickell is an acting assistant professor in the Department of Global Health at UW. His work focuses on optimizing the identification and management of children with malnutrition. Dr. Cyrus Mugo completed medical training at the University of Nairobi in Kenya and MPH in Global Health from the UW. Dr. Mugo is a senior research scientist in the Department of Medical Research at Kenyatta National Hospital in Kenya and a PhD candidate in the Department of Epidemiology at UW. His research focuses on HIV treatment support of adolescents, including treatment adherence through the use of WhatsApp messaging. So with that, I'd like to turn it over to this amazing panel to talk about innovative mHealth approaches to reach children and adolescents globally.
Donna, and thank you everyone for the invitation to speak today. Today we're going to be talking about innovative mHealth approaches to reach children and adolescents globally. Next slide. These are our disclosures. And our goal today, as Donna mentioned, is to give you a high-level overview of the different ways mobile communication technology can be used to support the interconnected health of women and children. Specifically, our learning objectives are first to analyze approaches to use mobile communication tools to support pediatric and adolescent care in resource-limited settings globally. Second, to evaluate potential uses of mobile communication tools in patient care and research. And thirdly, to compare applications of mobile health to address pediatric care challenges in different healthcare contexts. Next slide. So today I'm going to start us off with an overview of mHealth and in particular, a text messaging platform that our group has developed and iterated over the last several years named WACh, and share some data from completed and ongoing studies using this platform. Then Allison will discuss mHealth for adolescent sexual and reproductive health and remote data collection. Kirk will discuss mHealth for children with acute malnutrition. And Cyrus will talk about mHealth for peer-to-peer interventions in adolescents living with HIV. We'll have time for Q&A at the end, so if you could please hold questions, we'll take them all together at the end. So first, to ground us in some definitions, mobile health, or mHealth, is the use of mobile wireless technology to improve health. mHealth can be used for a number of different applications shown here. And the research that we'll be discussing today focuses on primarily on patient education and awareness, as well as healthcare worker communication and training, and a little bit on remote data collection. Next slide. So why are we interested in mHealth? So this graph shows that over the last 15 to 20 years, there's really been an explosive growth in access to mobile phones, including both in high-income countries like the US and low-income countries such as Kenya, where the work that we're going to talk about today is conducted. So what this means is that mobile technology presents a really ubiquitous and affordable way to reach people beyond the clinic and potentially overcome disparities in access to facility-based care. Next slide. So our group in WACh started working in this space around 2013, led by Jennifer Unger, an obstetrician gynecologist who's since moved to Brown University. So through a collaboration with the UW Computer Science Department, as well as Kenyatta National Hospital and the University of Nairobi in Kenya, this team developed an mHealth platform named Mobile Solutions for Women and Children's Health, or WACh. Next slide. So WACh is a custom human-computer hybrid software system. So it's hybrid because the outgoing messages to participants are automated and pre-scheduled. Participants can then respond free of charge at any time. And then a human nurse responds manually to incoming participant messages. Next slide. So the premise of WACh is that barriers to facility-based support impair women and children's health. So this applies, for example, to adherence to medication and retention and care in women living with HIV. This graph summarizes retention over time in Zimbabwe's healthcare system. The graph is a little busy, but the basic message here is that by 1 year postpartum, less than 50% of women were still adherent to their antiretroviral medication, and only 70% was still in care. Next. It also applies to breastfeeding in uptake and continuation. So this graph shows that the UN has set a target, shown in red, that by 2030, 70% of women should be initiating and continuing exclusive breastfeeding to 6 months. But globally, only 40% of women actually achieve this. Next. So our hypothesis in underlying WACh is that informative, supportive, and interactive SMS text messaging with nurses can improve patient engagement in various target health behaviors. So our team has employed a human-centered design approach guided by formative work with Kenyan healthcare workers. And through this approach, we've developed an intervention that facilitates nurse workflow using approaches that are probably very familiar to many of you in your own clinical care. So we have a dashboard that prioritizes tasks. And on the right, we have a text message conversation interface that supports the nurse to quickly get participant context and answer participant questions. Next. We also use human-centered design with peripartum women, so the end users of this intervention, to develop message content. So this graphic summarizes the pregnancy to postpartum timeline and the messaging themes over time in one of our studies. So in our formative work, participants told us that they really wanted holistic messages that address their evolving needs during pregnancy and postpartum. So we incorporated messaging topics that evolved with gestational age and the infant's age. Next slide. So our team has conducted several randomized controlled trials using this platform. All have been focused on perinatal populations or mother-child dyads, and they've explored a range of interconnected maternal and child health outcomes. Next slide. So in the first WACh trial, the PIs, Jennifer Unger and John Knuthia, were interested in whether WACh could improve exclusive breastfeeding and postpartum contraception uptake in women receiving antenatal care in Nairobi. So 300 pregnant women were enrolled and randomized. And what we found was that women who received interactive two-way SMS through the WACh platform, shown in green, had higher levels of breastfeeding to 6 months, and also higher levels of, earlier uptake of contraception, as you can see on the right, which was a very exciting finding. And we've since validated the effect on contraception uptake in another study in Western Kenya, led by Liz Harrington. Slide. So this first WACh study was really encouraging and prompted us to ask a series of interconnected questions. The first is, which outcomes can the WACh strategy support? We were interested in thinking about neonatal health, sexual and reproductive health, and pediatric nutrition. Second, how should mHealth interventions, if effective, be integrated into resource-constrained health systems? Third, can we leverage mHealth for real-time data collection? And finally, can we leverage mHealth for peer-mediated interventions? So I'm going to spend a few minutes today talking about how this strategy can be used to promote neonatal health, as well as research on how a strategy like WACh can be successfully and sustainably integrated into the resource-constrained health system in Kenya. And then I'll hand over to my colleagues to discuss these other topics. So in reviewing the messages from that first WACh study that I showed you the data from, we found that although neonatal health was not specifically a focus of the programmed messages that went to participants, postpartum participants asked a lot of questions about their infants. So, and what we found was that in the resulting interaction with the study nurse, the intervention allowed timely identification of infant illness and referral to the clinic when needed. So in this conversation on the left, what we see is the mother reporting that her infant is not urinating. And the nurse then asks a series of questions over the course of the next 30 minutes to determine the severity of the baby's condition and ultimately refers her to the clinic for urgent care. So here in this conversation, WACh really brought the benefit of a healthcare worker into the woman's home and allowed for referral of a sick infant. And so conversations like this provided the inspiration from using WACh for neonatal health. So WACh Neo, which is led by Jennifer Unger, is an ongoing NIH R01 evaluating the effect of WACh for neonatal health. So this trial, as I said, is ongoing. We're expecting data in the next 18 months, but I don't have any data from that to show you just yet. One thing I want to highlight is that in all of these trials, the intervention was delivered by dedicated study nurses, not providers who were part of the standard clinical services. Next slide. So this leads us to the second research question that I highlighted. How should mHealth interventions be integrated into resource-constrained health systems? So while we were developing WACh Neo, we had some really interesting conversations with Kenyan policymakers. So when we told them about WACh, they were excited about the strategy, but they actually suggested that rather than using nurses, as we had done in our previous studies, a more sustainable approach would be to have this intervention be delivered by community health volunteers. So community health volunteers are a large cadre of community-based lay health workers who conduct home visits, provide education and prevention services, refer families to clinical care, and typically have pretty limited healthcare training. So this is quite a different group of workers from nurses who in Kenya are really the primary providers of healthcare. So we had a series of questions about this approach that policymakers recommended. So first, how would we go about adapting the MobileWatch intervention for delivery by community health volunteers? How would we integrate this into their existing workflow? Then would this model improve clinical outcomes? And we were specifically interested in neonatal health. And then how would this affect the workflow of community health volunteers, and what factors would enable or inhibit implementation in this way? So in order to answer these questions, we're currently conducting a trial to adapt the MobileWatch strategy for delivery by community health volunteers, and evaluating both its clinical impact on neonatal health and also using implementation science methods to understand the effect of this strategy on community health volunteer workflow and what would need to be in place for this to be successfully implemented. So we're just at the start of this study. We're currently launching intervention design. So stay tuned for results over the next few years. So with that as a starting point, I'm going to hand over to Allison.
Thanks, Keshit. Can you advance to the next slide? Good morning. Today, I'm going to be discussing mobile health to improve adolescent sexual and reproductive health. Next slide. And I just want to start by highlighting that adolescents do have very diverse sexual and reproductive health needs, which often require multi-dimensional solutions. And to illustrate this, I just want to contrast two different scenarios of two adolescent girls from different regions of the world. On the left is a photo of a 13-year-old unmarried Tanzanian girl who's been brought to a family planning clinic by her mother. And the mother says, "I can't protect her from rape, but I can protect her from an unwanted pregnancy." And just to contrast this with a young couple who is married and the woman is currently pregnant, she desires to have an IUD to prevent a future pregnancy and return to school. So you can see the life stories of these adolescents are quite different, and they would likely require quite different solutions. Next slide. Adolescents do face unique barriers to accessing and receiving sexual and reproductive health care, and their needs are frequently unmet. Some of the unique barriers that they face include lack of access and awareness of services, stigma, discriminatory policies, and judgmental providers that are often related to their age or beliefs about what their sexuality should be like, and unique considerations regarding their privacy and confidentiality. So approaches to overcome these barriers would need to be safe and effective, affordable and acceptable, but importantly, accessible and desirable. And I highlight these last 2 points because we have found that in our work in Kenya that SMS can be a low-tech solution that can offer really great reach to adolescents and can really harness the power of this technology in innovative ways to improve health. So we're really striving to find solutions to adolescent sexual and reproductive health that are derived from the communities that we work with. And in our work over the last several years, we have found a high demand for this type of intervention, a text messaging intervention. Next slide. Last year, there was a NICE review that came out to put together a conceptual framework for mobile health for adolescent sexual and reproductive health. And they identified 3 specific mHealth applications that show great promise, including client education and behavior change communication, data collection and reporting, and financial incentives and reporting. Next. I'm going to highlight a third domain that sort of straddles data collection and the behavior change communication, which is the use of decision support tools. And I'm going to focus on two completed projects today and one project that is in development that is related to each of these domains. Next. Starting with our decision support tool. In 2017, we developed a family planning counseling decision aid that we called the Interactive Mobile Application for Contraceptive Choice, or IMAC. This work was led by Ruby Deb, who was a PhD student in nursing. And the counseling decision aid was logic-based, so it had an algorithm that determined the content that individuals received. It was designed for self-administration prior to seeing a provider. And the intention was not to replace the provider, but rather support and augment services that the provider was already giving. And this was designed for initial counseling. This iteration of IMAC primarily focused on fertility planning and family planning. And within the family planning domain, the application addressed things like side effects, dosing, concealability needs for providers or for family members, access to services, but really importantly and uniquely in this application was a focus on preferences and values. So how does family planning fit into an individual's life? What methods are most likely to work with them based on what their needs are and their values? And we are developing this counseling decision aid and a new intervention that I'll talk about at the end that will integrate family planning along with HIV care and potentially other sexual and reproductive health services. So addressing things like drug-drug interactions. Next slide. Next, I'm going to talk about another study that we completed that used mHealth for data collection. Next. We conducted a study in 2018 called the Mobile Data Collection of Contraceptive Use Behaviors and Experiences of Kenyan Women and Adolescents, or mCube for short. This study enrolled over 1,200 women who were seeking family planning and maternal health services who were registered into an SMS registration system. These women were all from 10 different facilities in Western Kenya, shown on the lower right-hand side of the slide. After registration, women received weekly surveys for 24 weeks. Next. And this is just an example of a type of survey that they would get. It was a question that would have a coded response with a numerical answer. So things like 1 for yes and 2 for no. So in this question, we were asking about whether anyone had side effects after using Depo-Provera or the injectable method of contraception. If someone said yes, there would be follow-up questions related to the side effects. If they said no, they would skip the questions that were related to side effects. Next. And just to note for this audience that nearly 40% of the participants were youth under the age of 25. Next. So here you can see the output from the raw data that was collected through the SMS system, and this was a variable on what method women were using. This unique mode of collecting data can help identify patterns that might otherwise not be discernible through routinely scheduled visits. For example, you can see that there are multiple method switches. Each color represents a different method. So when you see something go from green to blue, that's switching from an injectable to an implant. Or the red boxes indicate a time when the method has been discontinued. And we can use statistical analyses to fill in the gaps and really highlight the patterns in more detail. But this approach really could be harnessed to support women as they experience things like bleeding side effects. So if this slide was about bleeding side effects, we may be able to intervene at that moment when someone is having a side effect to help guide decision-making around whether women would like to switch a method, discontinue a method, or come in to be assessed by a provider. This would avoid unnecessary visits and provide real-time counseling. Next. Last, I'll just talk about a project that we're just starting that will harness the WACh platform. Next. So our new project that we're hoping to launch in fall of this year, funded by an NIH R01, is called WACh Empower. It is designed for women who are living with HIV who are coming in for care and would receive family planning at an initial baseline visit through a redefined version of the WACh tablet counseling tool. They would share a summary screen with a provider, again, not replacing the provider, just augmenting what the provider is already doing. And then during the follow-up period over 2 years, we would use the WACh system to provide that two-way interactive message system to support their reproductive health needs. And in this project, we are trying to expand beyond just family planning, but think about their reproductive life planning needs across all of their needs. And finally, next, we want to couple these 3 technologies together. So while mCube used a different platform, mSurvey, that was a locally derived company in Kenya, we will use the same technology to try to integrate a WACh so that we can not just have the free-form open text fields, but also this numerical response that helps us capture better data on key outcomes and behaviors. Next slide. So for WACh, we have lots of questions that we want answered. What's the next frontier for WACh? Well, first, we are trying to combine this decision support tool, which uses an open data kit or ODK platform for initial counseling with ongoing support through the WACh platform. So we're trying to integrate that to avoid collecting data in more than one place. Can we incorporate data collection via this coded response for SMS, this numerical key that would allow us to capture data on key behaviors and outcomes and do better triage and data collection to avoid unnecessary clinic visits? Can we tailor counseling messages for adolescents? What things are unique to adolescents versus universal for all women? And how can we address the duration of support with dynamic needs? As people navigate their reproductive life plans, they may have changes over time to want to prevent a pregnancy, to shift to a different method, or to plan a pregnancy. And we are trying to adapt our platform so that it's dynamic and can respond to these needs at critical times when people need the services. Next. And finally, how can we best support, but rather than replace providers? What are essential services that we want to retain from the provider perspective, or maybe reiterate with our technology versus offload? What are some of the gaps that the technology can serve? And then how do we balance what providers want and need versus what adolescents want and need? Next slide. So I'd just like to thank all of our collaborators and funding across the various projects. And next, I'm going to turn it over to Kirk.
Thanks, Alison. Hi, everybody. My name's Kirk. I'm going to be talking today about our efforts to improve the identification of children with malnutrition in Kenya. I'm specifically going to talk about one type of malnutrition, which is called by WHO wasting or acute malnutrition. It's basically a low weight for height. It affects 52 million children globally each year, and it's the underlying predisposing factor to over 1/3 of child mortality before the age of 5. So it's just a huge contributor to global mortality. I do this work with my co-PIs, Christine McGrath at UW and Benson Singer at Kemry. Next slide. We specifically work with the community management of acute malnutrition programs. So these are really efficacious programs that identify malnourished children in the community and treat them with this kind of package you can see being handed out at the bottom, which is called ready-to-use therapeutic food, or RUTF. It's essentially a peanut butter-based nutritional supplement, which has proven to be enormously effective. Next slide. If you can identify a child in the community before they get a medical complication like diarrhea or pneumonia, the treatment is enormously successful. 98% of those children recover, usually in the period of about 6 to 8 weeks. The CMAM programs identify those children in the community using these mid-upper arm circumference tapes that you can see being used here on this child. And they do that. That's called active screening, where they're going door to door with community health volunteers to try to find those children. The other way of identifying the children is passive case identification, when those children present to hospital with an acute medical complication. Unfortunately, if you wait until that point, the mortality, case fatality rate rises and is usually between about 10 and 20% at that point. So it's obviously much, much, much better to identify these children in the community. Next slide. If you look at within camp settings, refugee camp settings, where a lot of the CMAM programs operate, they have really good coverage. They're able to identify about 75% of the wasted children in a very fixed, stable setup. But when you get into more endemic settings in cities like Nairobi or Mombasa, or in the rural settings where we work, coverage really drops. The cities are just too dense. The rural populations are too dispersed. People move around a lot, which they don't do in the camp settings. So overall, if you live in an area that is covered by a CMAM program, they're really only, if your child becomes wasted, there's about a 38% chance on average that they would be identified by the program. But many areas in the world aren't covered by CMAM programs. They can't afford the program itself. And so UNICEF estimates that only 17% of children globally who have this form of malnutrition are identified. So this is just a huge gap. We have a treatment that's 98% effective, but only 17% of children are receiving it. Next slide. So we've been working with KEMRI to adapt to the mobile watch system and develop this idea of maternally administered malnutrition monitoring. And we're testing this in a clinical trial called mHealth. Next slide. What we know, what we've seen out of research, mostly from West Africa, is that mothers can use these mid-upper arm circumference tapes too. In fact, they can use them really quite accurately, and some evidence suggests that if you give a mother a mHealth tape and you train her how to do it, she'll actually identify malnutrition in her child faster than the community health volunteer would have, just because, you know, she has such incredible access to her child. But you still end up in this situation then that you have a mother who's identified her child has a problem, but she faces all of these barriers to access healthcare. We know that she may choose to go to family, to friends, to a pharmacy, to a traditional healer before she comes to the hospital or the nutrition clinic. So we thought that the mobile watch system, which is really excellent at addressing some of those barriers, might be a really great way to facilitate treatment if a mother identifies a problem with her child using this mHealth tape. Next slide. So we recruit mothers at vaccination visits. Usually they're 6 or 9 month vaccination visit, and we randomize them to this maternally administered malnutrition monitoring system, or an SOC arm where we just do active and passive screening. Each week they get a text message which delivers some age-appropriate health message and a prompt to use their mHealth tape to measure their child and return the colors that they see on the mHealth tape or the value that they read to our computer system. Those colors and values are then reviewed by our study nurses. And if there's an issue, we then either phone or SMS message with the mother and ask them to come to clinic, or if they're unable to do that, we go to them. We confirm the reading to see if the child really does have malnutrition or not. If the mother was wrong, we retrain them. If the mother was correct, we then enroll that treatment of that child in the treatment using this RUTF. Next slide. I wanted to just tell you a little bit about the settings that we're working in, because I think it's very important context. The first place that we work is Migori County, which is a rural county on the western side of Kenya. And this is a very typical homestead in Migori. It's the most green, verdant, agriculturally productive place I've ever been in my life. The nutritionists describe the type of agriculture you're seeing here. This is sugarcane. They describe it as growing sugarcane to your front doorstep. So there's not a lot of household food production. It's all commercial food production. Next slide. The other county we're working with is Homa Bay, and you can see this big body of water. This is actually the lakeshore of Lake Victoria. Lake Victoria is, I believe, one of the most productive inland fisheries in the world. Homa Bay, as you can imagine, the shores of the lake are also very agriculturally productive and green. So both these communities are actually in some ways agriculturally rich, food productive communities, and yet they both have a prevalence of 4 to 5% of children having either moderate or severe wasting, which I think just underscores that malnutrition, wasting is not purely a disease of food insecurity. It's actually primarily a social and economic disease, as well as there is an infectious component. These communities have a lot of malaria, pneumonia, and diarrhea as well. They actually have the worst child health outcomes typically in Kenya. Next slide. So I'm not able to present to you the quantitative results because it's a randomized control trial, and we won't get the quantitative results released until July. However, we just completed some qualitative work just before Christmas that I'm able to share with you. And what we have seen is that the caregivers in the MAMS arm, in this SMS arm, are using the mid-upper arm circumference tapes far more than we expected. We asked them to use it once a week. Many of them are using it 3 to 4 times a week. Some of them are even using it each day. And we begun to get the impression from the qualitative data that when they are seeing changes in the readings, in the colors on the tapes, they're actually beginning to tailor and adapt their child's nutrition and seek help from community members, grandmothers, friends, about how to change their child's nutrition if they're not improving or at least staying stable on their measurements. So this actually is considerably more profound behavior change than we were actually bargaining for in the trial. So it's going to be very interesting to see how that plays out in the results. The other very interesting piece is that we're really seeing fathers being brought to the table with this. Often there's a bit of a disconnect between maternal agency and paternal agency in these communities, but there's a really united effort around child nutrition and having, healthy child nutrition. So that's great. There are obviously challenges that were raised. Mothers didn't like the fact that their measurements would vary every time they took one, even if it was immediately after one another. Shared phones are a real challenge for all of the mHealth studies we're working with. And the timing of messages coming when they're at work and things like that was a bit of an issue. Next slide. So I think my take-home messages today are that there's this huge kind of fatal global gap in identifying children with malnutrition, but this family mHealth approach is really promising and is very highly desirable to Kenyan caregivers. And finally, that we're expecting our full results in July of this year. So we'll be sharing that in many forums. Thank you. And handing over to Cyrus.
Thanks very much, Kak, Cyrus, and I will present Vijana Smart, a WhatsApp-based HIV treatment support intervention. While this fits in the broad categorization of the mHealth interventions presented today, it's a little different from the other mobile watch projects. This project utilizes peer groups, smartphones, and is delivered manually rather than the semi-automated messaging that we've seen in the previous studies. Next slide. So these are the two people who led the study, the Vijana Smart study. It was a large group led by Dr. Irene Inwani of Kenyatta National Hospital and Dr. Keshet Ronen of the University of Washington. Next slide. So SMS messaging with healthcare workers had been shown to improve treatment adherence with adults, but few studies of mHealth approaches had been applied for youth or adolescents living with HIV. We learned that since 2014, youth living with HIV in Nairobi had been supporting each other through spontaneously formed WhatsApp groups. And we aim to learn how these groups functioned and the benefits the youth accrued from being members. Next. So we conducted surveys with youth from 3 clinics in Nairobi and found that across all the 3 clinics, age was associated with smartphone access. Close to 70% of youth age 20 and above had access to a smartphone, whereas only 40% of those who were aged below 20 did. Gender and orphanhood were not significantly associated with smartphone access. Next slide. So we also conducted in-depth interviews with adolescents and youth in the organically developed WhatsApp groups. This was in 2 large facilities in Nairobi. The study counselor, a young adult herself at the time, also joined the groups after we sought the group members' consent. Looking at the in-depth interviews and also a content analysis of the WhatsApp messages, which we imported anonymously, again with their permission, we observed the following themes in how youth use existing WhatsApp groups. And one, youth derived companionship support from the groups. As we can see from the quote, one person saying, sometimes you have very many friends, but they do not know about you. And if you tell them about yourself, they may abandon or isolate you. So I wanted to find some friends who we can talk freely and tell them about what is challenging me. This was an from an interview, a 23-year-old. And looking at some of the content in the WhatsApp groups, we see that they supported each other in practical and instrumental ways. For example, with reminders to take treatment. You can see from the second group of quotes, where we see someone urging those who take their pills at 6 o'clock in the morning that, it's 18 past, but it's still not very late, and that they can take their pills. And they also support each other emotionally with encouragement and celebration. The last set of quotes there is one of the group members who had delivered a baby who turned out to be HIV negative and was highly congratulated, and the team was very, very happy about that. Next slide. So with this background, we set out to develop a standardized, moderated mHealth intervention that integrated peer and healthcare worker support. The main goals of the intervention are to improve adherence and retention in care, and we thereafter piloted the intervention. Next slide. So this is the conceptual framework for the intervention. We created two age-segregated gender-mixed groups of approximately 25 youth each. So we had a group for those who are under 18 and over 18 years. And we also had the study counselor facilitated the groups and would send out weekly messages and stimulate discussions in the group. We also had social support. The social support structure in the group was in the 4 thematic areas: informational, emotional, instrumental, and companionship support. And the outcomes were HIV knowledge, depression, HIV stigma, and treatment adherence. That's what we were interested in improving. Next slide. Yes, thank you. So here we look briefly at the content of the 4 thematic areas. The first is information, and here we look at items like medication side effects, information on medication side effects, information on positive prevention, which is basically preventing a new infection for a person living with HIV, discussion on the concept of U equal to U, the undetectable equal to untransmittable messaging, where people living with HIV with a low viral load, that is, according to several trials, below 400 copies per mil, cannot transmit HIV. Also talked about pre-exposure prophylaxis for partners, talked about prevention of mother-to-child transmission and family planning. We also talked about instrumental support, that is reminders to take medication, how to prepare a well-balanced meal on a budget, and very importantly, self-disclosure of your HIV status to others. Next slide. We also had content on emotional support, that is how to deal with stigma and poor mental health. And with companionship support, we had the counselor encouraging group members to simply be together in unstructured ways, share positive events of their day, share challenges that they are experiencing in their life. Next slide. So the Vijana Smart facilitator sent push messages manually, and they had a dedicated tablet. All messages developed were stored in a Google Drive repository accessible to the facilitator, and they would simply copy-paste from the Google Drive into WhatsApp. The message repository contained calculated fields with conditional formatting to highlight when messages were due to be sent based on the group start date. And there were some pointers to the facilitator. For example, the facilitator would not use HIV-related terms directly. For example, avoided HIV, use of ART, words like viral load, CD4. While these terms may be used in the individual messaging with participants, they were avoided in the group. They had a dedicated phone, as I mentioned, the tablet, for facilitating the group that was separate from their personal phone. And this enabled the facilitator to adhere to privacy needs for the group and also create boundaries between work and their own personal engagements. And they set up a reminder to send the messages. There was an alarm and also a calendar invite with about 30-minute allowance so that there was efficiency in sending out these messages. Next slide. So we enrolled 55 participants to the intervention. Nearly all participants had used a phone to message or to call prior to the intervention. while about 2/3 had used a phone for WhatsApp or social media. The median age was about 18 years, 2/3 were female, and about half were in school. And the median duration since starting ART was about 4 years. Next slide. So we assessed participants at enrollment and 6 months after joining the WhatsApp groups on treatment adherence skills, that is treatment information, motivation to take for adherence, and also treatment adherence behavioral skills. And there was improvement in the information and the behavioral skills, but there was an unexpected increase in stigma, specifically internalized stigma, and no changes were seen in social support, depressive symptoms, and treatment adherence itself, though the behavior skills were improved. Next slide. And so in summary, the Vijana Smart WhatsApp group is a promising and acceptable mobile health intervention. Our pre-post analysis indicated improved youth knowledge and skills for treatment adherence. The pre-post analysis also indicated increased internalized stigma at follow-up. It's unclear if the increased stigma was because of youth developing language to name the stigma, or if sharing experiences of stigma in the group increased people's internalized stigma. And this needs to be investigated longitudinally in a future study. And so one of the next steps that we've had is a larger study that was randomized, and is going to look at how these groups can be used for better support for the adolescents. We also created a manual for facilitated WhatsApp groups, and though not published, this manual was presented to the facilities and at their requests so that they can manage their own groups. Next slide. A big thank you to our study participants and our teams in very many institutions that helped get this up and running, from UW, Kenyatta National Hospital, University of Cape Town, and University of Wisconsin. And our funders, that is the UW and Fred Hatch CIFA. Next slide. So I have the honor to give the takeaways for the presentations that we had today. And number one, we can conclude that mobile technology can extend the reach of healthcare beyond the clinic for client behavior change, decision support, and data collection. Perinatal populations, caregivers of young children and adolescents in Kenya, enthusiastic users of mobile technology. Mobile watch improves exclusive breastfeeding and contraception uptake in Kenya. SMS and digital peer groups have potential to improve neonatal health and adolescent HIV care. And research is needed on sustainable integration of digital tools into health systems. Thank you very much. We welcome questions.
Thank you very much to the panel. That was really an impressive presentation about innovative mHealth approaches across 4 different health issues that affect children and adolescents globally. So the floor is open for questions, and I see that there is one in the chat already. Kirk, this is for you. Given that smartphones with cameras are becoming more prevalent, any thoughts about using photos of edema to identify children with kwashiorkor or edematous malnutrition?
Yeah, thank you, Indy. I think that's a great thought, and I'll also bounce it onto the other members of the panel. My feeling is that data remains an issue, I think, both in terms of coverage and cost, particularly if we're looking at families that are vulnerable to malnutrition. There'll be some barriers there. I suspect that within the next kind of 10 years that situation will change, as the kind of SMS phone call situation has changed in the previous 10 years. But at the moment, I'm a little skeptical about anything that requires data. I think the other thing that a lot of people have been interested in is developing an app that can do anthropometry and assess edema and vital signs. I will say I'm pretty app skeptic, and I think we'll probably get there in 10 years time, but at the moment I don't know that we quite have the platforms in most low middle income countries to widely support an app that would identify these kind of most at-risk families. But would love to hear what other people on the panel think.
Yeah, I would just add that when we looked at smartphone access, Cyrus showed the data on smartphone access in Nairobi. Outside of Nairobi, including in Western Kenya, where Kirk's studies were, access is quite a bit lower. So I think that is important to think about. But I would add that the Kenyan Ministry of Health has a sort of a digitization plan for community health volunteers. And so I think that in the next 5 or so years, we'll see that community health volunteers are equipped with smartphones to facilitate their workflow. And so I definitely think that thinking about these types of approaches in the hands of community health volunteers who are conducting home visits, I think could definitely be an approach.
So Indy has an additional question or comment, and I think this is really interesting. How have you negotiated with mobile telephone companies? You know, and he mentions provision of free services donated by the companies, for example, during Ebola outbreak from 2013 to 2015. What have been your experiences across the panel with negotiating with the mobile telephone companies?
I can comment on that. I don't know, Allison, if you have anything else to add on this. It is definitely a possibility. It often gets brought up. We ourselves have not had a lot of success, but I think that there are definitely NGOs, particularly large NGOs, that have more success doing that. It ends up being sort of, you're working with the philanthropic arm of the telecom company, so it's often a lot of just finding the right person to talk to and aligning with the timing of when they're planning to make a donation, et cetera. So it's a little hard to rely on it.
And a really great question from Dr. Walker Harding about, well, first of all, about your fantastic presentation, but then how do you approach having healthcare systems actually adopt these tools into standard care?
I think the first step is really just working with the communities and with the government to begin with to kind of understand what might be possible for integration later on if it's effective. And we're kind of upstream, making sure it works first before we get there, but to always be with that planning mindset. So, I mean, each project is a little bit different. Kirk and Kesha probably have more to say about that, but that's sort of where we start, is just, you know, having the conversations at the beginning so that we can plan for integration later on, and trying to make it work with technology. The technology needs are changing so much with other, you know, SMS platforms even that the Ministry of Health is operating, and how do we work with that? Depends on whether, you know, these interventions become something that is useful and that they want to have in the future when we're ready to show that they work.
I have a related question. I imagine that ministries of health and ministries of finance will want to know how much added workflow there is to existing providers, especially when responding to personalized messages, and what is the cost related to this? I know in the studies you've presented, I think as I understood it, you had research personnel who were responding to the personalized messages, but are you aware of in settings where providers, you know, in the health system are providing these responses, what the time and cost estimates are for this added workflow?
We did a costing. Oh, go ahead.
Oh, sure. Yeah, just for the testing. Yeah, so in an unrelated, well, it's related in a different study during COVID. This did come to life, and so when COVID hit, we really wanted to continue with many of our programs. And when we went to the sites, we actually met quite a number of the studies. Quite a number of the sites had already adopted SMS and WhatsApp messaging with their patients to keep, you know, the contact between facility and patients. And we did note at that point that this is quite sustainable if there's, you know, support in other ways, but at least the platforms are in use on a routine basis.
Thank you. Kashat, did you have anything to add? And then we'll move to, I see Kirk has his hand raised.
Just two very brief comments. The first is that we did do a costing analysis for one of our studies. I don't have the numbers in my head, but I can definitely share the citation for it if people are interested. And then just to reiterate that that is a big focus of the current R01 that we have, looking at what the workflow impacts are on integrating this into CHV workflow, because you're absolutely right. Providers are very busy. So how do you add this?
Kirk?
Yeah, I wanted to add to the conversation about, how do we get this into healthcare systems, and just to say that, I think we're a very small program doing this at the moment, but there are a lot of large companies and nonprofits that are kind of taking the mHealth world by storm, and I see part of our role as informing the strategies of those other larger companies that are, very engaged with ministries of health, and also very engaged with kind of bilaterally funded programs like PEPFAR and things like that. During COVID, a couple of CMAP programs reached out to us and said, your system would be great during COVID because we could screen all the kids and not have to go to people's houses. Can we try to do it? And after some discussions with them, and unfortunately, we just wouldn't have the capacity to support them doing that, but a larger program, would be able to make that successful. So I do think we also, as well as informing ministries of health, as much as I hate to say it, we also have a role of informing the private sector or NGO sector about how to develop these approaches more commercially and at scale.
Mm-hmm. Allison?
Yeah, I just wanted to add that, one of the goals would be to try to make it cost neutral, or in a way that would alleviate some of the additional costs. So if you are preventing someone from having to come into the visit, all of that time that is spent with a provider, waiting or doing the other assessments that might happen in an in-person visit, if that can be shuttled to someone who's maybe already, whether it's a call center kind of model or it becomes part of the workflow of what an individual provider does. I think particularly coming off of COVID and with this move towards telehealth in general, this is potentially just another way of doing telehealth in a low resource setting where you could do it by SMS rather than, like a Zoom call. So whether that can work and whether it can take the cost down would be the goal.
Yeah, it'll be interesting to see how that plays out. I mean, I think as for those of us who provide care in the US, we're very familiar with the added work that comes with these technologies, and being able to directly communicate with patients, like, for example, through EMS, through electronic charting. So, I think for a lot of us, we feel like it's an added work as opposed to shifting what we do. But these are really remarkable technologies that can really improve patient care, and seeing how they can be folded into routine care will be really important. I have and thank you, Kashat, for providing the costing paper. I don't see any other questions in the chat, so I think I maybe have one last question for perhaps Allison and Cyrus. This would be best directed to you. How do you manage confidentiality issues among adolescents and youth when there are phones that are being shared across household members rather than being individually owned? This is really common. And how do you monitor for unintended harm?
Yeah, I mean, I guess I would actually build on the work that Keshet has done in the space around HIV infections and confidentiality there. So, it's an extensive consent process for sharing phones. For example, we would want to know if someone shares phones. We can tailor the messages, the tracks, the types of words that are used, the types of things that are agreed upon, what you can and can't say in a text message, that is all sort of built into the system in order to ensure that for example, we don't use the word medication unless someone has disclosed to the person that they have shared a phone with, if they are a phone sharer. So I would say that for adolescents, we're really just building on the same approach that we've used in HIV, that the same thing, would hold true for adolescents.
Yeah, and just to add that this privacy, I think, is the Achilles heel for a lot of these technologies. Even the biggest drawback, I think, even when starting these groups, has always been a discussion on how does this work out, and people don't get to know that HIV infected, for example. And I think this is something that we don't have good answers yet. I know in the study that came after Vijana Smart, there were discussions about moving away, for example, from WhatsApp and going to a different platform. I think Telegram was more preferred for this. So I think these are discussions that are ongoing, and right now I think there aren't very good answers.
Well, thank you so much for that. And I see we are at time, so really appreciate the panel. Thank you.
Thank you so much to all of you, and we will see everybody next week at Grand Rounds. Thanks, everybody.